Hello, my name is Bernard Bendok. I am pleased and delighted to be with you here from our beautiful campus at Mayo Clinic in Arizona to report on the new generation hydrogel endovascular aneurysm treatment trial. I have the distinct pleasure and privilege of serving as the chair of the Department of Neurosurgery at Mayo Clinic in Arizona and the William J. and Charles H. Mayo Professor at the Mayo Clinic Alex School of Medicine. I am very pleased to be reporting to you today on behalf of our Mayo Clinic and Northwestern research and operations teams, along with our many site PIs and their research teams as well. The HEAT trial was conceived as a master's thesis through the Northwestern Masters of Clinical Investigation program. The trial was designed by myself and my research team. The trial was funded by Microvention, but sponsored and operated through Northwestern University and Mayo Clinic independently. The data was housed by an independent third-party data track. Our only obligation to the funder was to publish the final results and notify them of adverse events. There was otherwise no financial relationship with the company. Aneurysm recurrence is a major issue. It can increase cost. If it results in additional procedures and rehemorrhage, it can increase risk to the patient, thus increasing morbidity and mortality potentially. It also adds to the need for follow-up imaging, which also adds to cost. Patient satisfaction is also likely diminished by this added need for more procedures and more imaging and exposure to risk. Factors that can affect recurrence are related to aneurysm factors, patient factors, and technical factors. Aneurysm factors include, but are not limited to, aneurysm size, neck size, rupture status, inflow angle, etc. Patient factors include, but are not limited to, smoking, and possibly other factors as well. Technical factors relate to coil design, the technique utilized, the use of assist devices, and likely variations in coil technology. Defining recurrence is fairly uniform in the literature. It relates to coil compaction. It can also be associated with aneurysm growth. Recurrence is typically defined as minor or major. The most commonly used scale is the Ramon scale. Complete occlusion is self-evident and is a grade 1. Residual neck is defined as grade 2, and residual filling of the dome is grade 3. The Myers scale is a bit more nuanced. It is shown on this slide. 100% is a grade 0 aneurysm occlusion. A grade 5, on the other hand, is less than 25% aneurysm coiling. In other words, most of the aneurysm is still filling. Long-term studies in aneurysm recurrence clearly demonstrate that this is a real issue. Delayed need for treatment is self-evident in the literature, as is the risk of rehemorrhage. Preventing recurrence has been a major focus ever since coils were initially introduced in the early 90s as a new tool to treat aneurysms. And there have been a number of strategies investigated to improve this problem. There have been attempts to improve coil design, which I suspect have had a positive impact. Bioactive coils, on the other hand, have been tested, but unfortunately have not been shown to make a major difference. Flow diversion is one of the later tools to be added to our toolbox, and they, I believe, have shown an impact in a positive way, but they do not work for all aneurysms. Gel coils is the topic of focus in this study, and these coils were introduced and have been studied as a way to improve outcomes and reduce recurrence. Why use gel? Gel, which is an inert substance, was felt to be a way to achieve better healing within the aneurysm, better packing density, and hopefully less recurrence. In animal studies, it was quite striking the difference between the histological outcomes between bare platinum and hydrogel coil. What was typically seen in animal studies was greater deposition of collagen materials in the aneurysm, greater scarring within the dome, and better healing at the neck. As you see from this slide, more neointima being laid at the neck in animal studies fairly consistently. The first generation hydrogel coil was studied and utilized, and what was found in the HEAL registry was that when more than 75% of coils used were hydrogel, there was a 0% recurrence. This was early encouraging data, and the HELPS trial further supported this early enthusiasm in that major recurrence was noted to be less often and frequent with the use of hydrogel coils. The PRET trial, on the other hand, while it did show a trend toward less recurrence with hydrogel coils, this did not reach statistical significance. Feedback on the first generation hydrogel coils was that they were associated with early swelling and stiffness that really limited the repositioning time. They required preparation for use, and this led to a limitation of widespread adoption despite the positive early results from the HEAL and HELPS studies. The second generation hydrogel coil, on the other hand, was designed to have handling characteristics that were very similar to platinum. And so, based on this new technology, back in 2010, we decided that there was a need to study the important question of whether this new coil, this second generation coil, did what it was claimed to do, to reduce recurrence. Did it have handling characteristics that were as easy and similar to platinum? And was it as safe? Those were the questions that were on our mind at that time. So we designed a study that was randomized, investigator-initiated, with follow-up that was greater than the vast majority of studies that had been done up to that point. The final follow-up was between 18 and 24 months, which was an improvement compared to prior studies. Our null hypothesis was that there was no difference in recurrence between bare platinum and hydrogel coils in treating 3 to 14 millimeter brain aneurysms up to 24 months after treatment. The primary endpoint was aneurysm recurrence. Any progression on the Ramon aneurysm occlusion scale at any time during follow-up was regarded as recurrence. The secondary endpoints were packing density, initial complete occlusion, aneurysm occlusion stability, major versus minor recurrence, morbidity and mortality, modified Rankin score, retreatment, aneurysm hemorrhage at follow-up. The study aimed to enroll 600 subjects in a 1-to-1 allocation at 46 sites throughout the United States and Canada. The inclusion criteria were untreated aneurysms, ruptured or unruptured, and patients who were 18 to 75 years of age with aneurysms that were 3 to 14 millimeters in diameter. The exclusion criteria were Hunt and Hess grade 4 and 5, concurrent intracranial pathology, and acute or uncontrolled comorbidities. For the coiling procedure, we did something very unique for the study that was very different from prior studies. In the platinum arm, we allowed the investigators to use any platinum coil of their choice as long as it was approved for intracranial aneurysm treatment. This allowed it to be more of a real-world study. In the hydrogel arm, we required that at least 90% of the coils used by length to be hydrogel coils. This addressed a criticism of prior studies where coils were often mixed, thus making it difficult to reach firm conclusions about hydrogel coils. The assist devices were allowed and used in this study. The statistical methods were as follows. The analysis of all outcomes was based on an intent to treat principle with 5% rate of type 1 error set. The HELP study had shown a 33% recurrence rate for platinum coils, and we used that as a benchmark. We aimed for a 30% less recurrence rate with the hydrogel arm. This allowed us to power the trial with 80% confidence with the 600 patients. The schedule of events for follow-up was quite rigorous, both for imaging and clinical endpoints. Our imaging core lab was led by Dr. Andrew DiNardo and John Scott, both of whom have no financial relationship with the company. It is very important to point out that the core lab was completely independent and they were blinded to coil type used. In terms of the flow of the study, 3,971 patients were screened. Of those, 600 were enrolled, 303 in the bare platinum arm and 297 in the hydrogel arm. When you look at loss to follow-up, it was very well balanced in both sides of the study, both at 3 to 12 months and 18 to 24 months, as shown in this slide. In terms of imaging follow-up, this slide also shows excellent imaging follow-up rates, also extremely well balanced between both arms of the study, and very competitive with similar studies in the literature. In terms of timeline, our first patient enrolled in June 2012. Final imaging follow-up and clinical follow-up was obtained on March 20th, 2018. In terms of site engagement, the top quarter of high enrolling sites account for 68% of trial-wide enrollment. 15 sites were considered low enrollers with less than or equal to 3 subjects. The median site enrollment was 13 subjects. When one looks at the top enrolling sites, you can see a wide variety of very reputable centers with diverse geography. In terms of the monitoring, it was quite rigorous. We utilized the risk-based monitoring FDA guidance approach. Full adjudication on primary endpoint data and AEs was performed. 19.6% of visits were triggered reviews outside the monitoring plan to address immediate risk issues. There were 189 monitoring visits. In terms of the reasons for early termination, they are what you would expect for a study of this type, and they are well documented in our study and shown in this slide, and very well balanced between the two arms of the study. When one looks at baseline characteristics, they're nicely balanced. There are some areas where there was a slight imbalance. These issues have been tested statistically and not been shown to have any impact on the final results. When one does a deep dive on ruptured versus unruptured, for example, one sees that there were more ruptured aneurysms in the bare platinum arm. On the other hand, there were aneurysm characteristics that were wide necks were more common in the hydrogel arm. Sidewall aneurysms were more common, on the other hand, in the bare platinum arm of the study. Location was also nicely balanced. Slightly more basilar aneurysms in the hydrogel arm compared with the bare platinum arm. In terms of smoking status, very well balanced. Location also minor differences, but overall, beauty of randomization led to a balanced baseline characteristics. In terms of the primary endpoint of the study, most important slide of my presentation, 15.4% in the bare platinum arm had recurrence, only 4.4% in the hydrogel arm had recurrence. This was statistically significant, and what's very interesting and exciting is that this statistical conclusion was reached both in the intent to treat analysis, which was the design of the study, but when we did a per protocol analysis, the study also came out quite positive in favor of hydrogel. Packing density was greater with hydrogel. Interestingly, even though slightly less coil length was needed in the hydrogel arm to coil the aneurysm, this was statistically significant. In terms of recurrence, when you look at bare platinum, unruptured versus ruptured, this was not a primary endpoint. But again, you see that there is a trend toward less recurrence, whether the aneurysm is unruptured or ruptured, a trend towards less recurrence with hydrogel coils. We also looked at the Myers scale. This scale is more rigorous than the Ramon scale. It has not been widely studied as an endpoint, but we wanted to include it. And even when using this scale that is more nuanced than the Ramon scale, we see that there is a statistically significant benefit to using hydrogel coils when it comes to recurrence. You have less recurrence with hydrogel. Quite striking difference when using this more robust, more nuanced scale, the Myers scale. Now, when you separate out major versus minor recurrence, so this is major recurrence, which is defined as any progression to a Ramon 3, whether it's from 1 to 3 or 2 to 3, we define that as major recanalization. And you see a statistically significant advantage of hydrogel when compared to bare platinum when looking at this issue. When you look at minor recurrence, again, a statistically significant benefit to using hydrogel when compared to bare platinum, 5% in the bare platinum arm versus 1% in the hydrogel arm. In terms of retreatment, this study was not powered to examine this issue. One would need a much larger study to detect a difference in this issue. There was a trend towards less retreatment with a hydrogel coil, but this was not statistically significant. In terms of initial complete occlusion, what was very interesting in this study is that the initial rate of complete occlusion, this surprised us a bit, was much lower with hydrogel when compared to bare platinum. But when one looks at follow-up, the bare platinum rose dramatically and exceeded the platinum coils. One hypothesis that has been postulated about this is that the hydrogel takes time to expand, and so that may have been an issue, but a very interesting finding. And in terms of clinical outcomes, what was very reassuring in the study is that the adverse events were very similar in the bare platinum arm and the hydrogel arm, with no statistical difference, although there was a trend towards more adverse events in the platinum arm. In terms of mortality, 3% in the bare platinum arm, 2.4% in the hydrogel arm. This is very reassuring because if the hydrogel coil had less recurrence but greater adverse events and mortality, that would basically have been a big problem in terms of whether one can make a recommendation to use this coil. In terms of modified Rankin at last follow-up, as you can see from this table, there was no difference in modified Rankin outcomes at final follow-up, also very reassuring in terms of whether the issue of recurrence justifies taking a closer look at hydrogel coil when treating aneurysms. In terms of coil used, this was very exciting and interesting finding from the study. An amazing 95.3% of coil used was hydrogel in the hydrogel arm. Even though we required only a minimum of 90, that minimum was exceeded by over 5%. And then when looking at the bare platinum versus hydrogel arm in terms of total coil length used, even though there was a greater packing density in the hydrogel arm, there were more coils used in the platinum arm. In terms of quality of life, we did study quality of life at baseline and follow-up. Not surprisingly, the quality of life outcomes did not differ between the two study arms. What was very exciting and interesting is that the quality of life improved in both arms of the study, and we are continuing to analyze this data. When looking at imaging outcomes, it was very interesting to note that when comparing the core lab, which was blinded, versus the site assessment of their imaging outcomes, there was very poor concordance. This was most striking at initial assessment or initial treatment. It improved a bit at 3 to 12 months and 18 to 24 months, but still a significant difference was noted. This is important because many studies use investigator-reported imaging outcomes, and this data shows that you really need to use a core lab that is blinded to assess these outcomes. When looking at hydrocephalus, there were 3 cases of hydrocephalus in the hydrogel arm that were attributed to the device, although it is important to note that these were all basilar aneurysms and all occurred at greater than a year after coiling. It is unclear to us whether this outcome can be truly linked to the device. Additionally, all 3 patients had an excellent outcome with shunting. When looking at the background literature, the GREAT trial is a study comparing hydrogel coils to bare platinum coils, and it was recently published. It did show a benefit to using hydrogel coil when compared to bare platinum coil. The major recurrence in that study was 12% for the hydrogel coil and 18% for the bare platinum coil. When examining the literature on recurrence between hydrogel coils and platinum coils, one can look at the HELP study, the PRET-1 and PRET-2, GREAT, and now our HEAT study. And what one sees is either a trend, and now with the HEAT study, a statistically significant reduction in recurrence rate when using hydrogel coils. When focusing down on hydrogel coil recurrence rates in comparison to platinum, the HELP study showed an advantage to hydrogel coils. There was a trend with PRET-1 and PRET-2, and a statistically significant better outcome with using hydrogel coils in the GREAT study. And when looking at second generation hydrogel coils, definitively shows that in treating aneurysms that are 3 to 14 millimeters in diameter, there is a statistically significant reduction in recurrence rates in this population at 18 to 24 month follow-up. This table summarizes the outcomes in terms of primary endpoints and recurrence in these 5 studies. In terms of the limitations, all randomized trials have limitations. It's very important to analyze them and report on them. One of the challenges we faced is the idea of blinding the operators. We did not feel that this was feasible, ethical, or economically viable. With the way aneurysms are coiled, to blind the user would be very challenging from a technical standpoint and possibly an ethical standpoint. Core lab versus site assessments were drastically different in my view. This is a focus for further study. This is a limitation, but perhaps even a strength of the study, the fact that we actually blinded the core lab and looked at this issue very carefully. Long-term risk of subrectal hemorrhage, which is the bottom line long-term issue, was not analyzed in the study. The study was not powered to look at that issue and was not, therefore, something we could make any conclusions about. The relationship between recurrence and retreatment is felt to be in some ways self-evident. On the other hand, this study was not powered to look at the issue of retreatment. Therefore, we cannot make any solid conclusions regarding that very important issue. Retention in these types of studies is always a challenge. We felt that our retention rates were very competitive with other similar studies, but this is an issue that could always be improved in future studies. In conclusion, hydrogel second-generation coils showed a significant effect on reducing recurrence for 3 to 14 millimeter aneurysms, both ruptured and unruptured. There was no difference in adverse events, and amazingly, there was only one crossover. I'd like to acknowledge and thank our amazing research team, both at Mayo Clinic and Northwestern. We could not have completed the study without their diligence, help, and support. I'd also acknowledge the amazing work of our imaging core lab, Drs. Andy DiNardo and Dr. John Scott. They did a fabulous job at very carefully and methodically and meticulously analyzing our imaging outcomes. I'd also like to acknowledge our very dedicated, disciplined, and focused Data Safety Monitoring Board led by Dr. Adnan Siddiqui, Dr. Michael Cawley, and Dr. Franklin Martin. No study of this type is possible nor ethical without a rigorous data safety monitoring board. And we had an outstanding, reputable, and diverse group of physicians here who led that effort, along with our statistician. I'd also like to thank our amazing research fellows, most of whom have gone on to very successful careers in neurosurgery. They were the backbone of the study in terms of all the nitty-gritty work that has to be done to make a study like this successful. I'd like to thank our amazing research investigators and their research teams, as well as the institutions they represent. Without their dedication, discipline, and contributions, their attention to detail, and commitment to the study, this study would not have been possible. So thank you to all our fantastic sites. Finally, I would like to thank you for joining us today as I shared the results of the new generation hydrogel endovascular aneurysm treatment trial from our beautiful campus here at Mayo Clinic in Arizona. Thank you very much.